Good afternoon, my dear foreign students. I am going to deliver your lecture about surgery. The outline of our lecture for today contains three main blocks. First one, the definition of the concept surgery and subject operative surgery and topographical anatomy. The second one, the history of creating surgery at large and the Department of Operative Surgery and Topographical Anatomy of the Volgograd State Medical University in particular. And the third block, the concept surgical operation and the classification of operations and their basic stages. Surgery is a divine art, the subject of which is a beautiful and sacred human image. Goethe. The term surgery was firstly introduced by Aul Cornelius Celsius. It derived from Latin words here and ergon means to walk. Much later, already in the Middle Ages, all people respected to medicine were divided into 5 groups. First group, doctors of medicine who studied it at universities. They were able to treat internal diseases, wrote out the prescriptions, gave an enema to patients, flushed the stomach, and other procedures. Second group, the surgeons who had no higher education and that's why were not allowed to write out any prescriptions, but still made phlebotomy, bloodletting, and lithotomy, and for their own advertisement used bones painted in yellow color. The third group, barbers who shaved clients and cut their hair. They also could start up a blood and make small operations. On these pictures you can see surgeon that makes his work. Here you can see a barber and his equipment. Also barber and the peasant. Another picture. Fourth group, bath house attendants who experts in the field of external diseases, especially dermal ones. The fifth group, frauds or charlatans who treated various wounds, usually with the help of worms rubbed together with other drugs. Thus, from the ancient times, surgeons were considered to be isolated caste of doctors. On this picture you can see the country charlatan, who treats the patient, who removes the abscess, I suppose. Surgical plot. Medicesta. The picture, a well-known picture that is called Visiting Doctors. And here you can see King Henry XIII gives Thomas Wicker the London Barber and Surgeon Union Act. Nowadays, the concept surgery can be defined as follows. It is a medical clinical subject aimed at treating diseases with the help of operative measures of the hands of a surgeon, supplied with special instruments and devices. This is the important definition, and you should write down it. And remember, I'll repeat once again. Surgery is a medical clinical subject aimed at treating diseases with the help of operative measures of the hands of a surgeon, supplied with special instruments and devices. Accordingly, our subject, operative surgery, is a doctrine about the technique of surgical operations, methods and rulers of providing operative measures. The single unit together with the operative surgery is realized by means of topographical anatomy. I will repeat once again the definition of operative surgery. This is a doctrine about the technique of surgical operations, methods and rulers of producing operative measures. Topographical anatomy is a doctrine about the collocation and interrelation of organs and tissues according to the regions of a human body. It's also an important definition you should write down. Topographical anatomy is a doctrine about the collocation and interrelation of organs and tissues according to the regions of a human body. It received its name from Greek words topos, that means place, and grapho, that means I write. Hence topographical or surgical anatomy. But it is quite possible that the former name of the subject, clinical anatomy or surgical anatomy, reflected the above mentioned sense better. The famous Shola Yefim Osipovich Mukhin, the teacher of the Nikolai Ivanovich Pirogov, told that the doctor who doesn't have knowledge of anatomy is not only useless but also dangerous for a patient. 100 years later, the outstanding Moscow obstetrician and gynecologist Gubarev managed to characterize this truth quite precisely. Without knowledge of topographical anatomy, there can be neither a surgeon nor a therapeutist, but only science and prejudice. prejudices. These words you can meet when you enter our department. Once again, I'll repeat those excellent words. Without knowledge of topographical anatomy, there can be neither a surgeon nor a therapeutist, but only science and prejudices. The stages of the development of the surgery. As you know, the surgery has a long history. It is possible to point out 4 basic stages in the development of surgery. The first period, the empirical one, dated from the ancient times up to the second half of the 19th century, before discovering narcosis, antisepsis, asepsis. Remember this period from the ancient times till the second part or second half of the 19th century. This period was rather long, but without narcosis, antisepsis and asepsis, or even excellent in technical meaning operations, were unsucceed. It was impossible to treat patients well. Nobody knows who was the first surgeon and when it happened. Whether he was an ancient Indian barber who 1,000 years before Christ carried out a rhinoplasty during intervals between hairstyling and shaving, or maybe the ancient Egypt priest who had a knowledge of producing cranial trepanation and managed to conceal the defect in the skull of a pharaoh means of a gold plate. Or maybe it was our ancestor who is depicted on the surface of a silver Scythian cup found not far from the Volgograd, taking out an arrow from the body of his wounded comrade. Or whether it even was the Catholic monk who, as inheritance, left 3 huge chests with 300,000 dents in the year, the majority of which, after checking, were claimed to be able-bodied. Now you can see the ancient illustrations that show us that the surgery appeared a very long time ago. Here, Anubis extracts the insiders of the deceased in order to perform the rite on the resurrection. Fragment of a set of surgical instruments from the temple of Koma on Borsa. Here you can see male genital surgery. Maybe it was circumcision, maybe castration. 10th century before Christ, wall of Saqqara in Egypt. Image of Hassi Ra, architect, surgeon and dentist. Here you can see Imhotep, ancient Egyptian doctor, priest and vizier. This is the ruins of the ancient Greece. Sanctuary of Asclepius in Epidaurus. Here ancient surgical instruments were found. Hippocrates. I suppose you know this name, and you can meet it in different ancient works and arts. Here on this picture, Hippocrates is illustrated as one of the fathers of rhinoscopy. Here you can see treatment of hip dislocation and prolapse of intervertebral discs by Hippocrates. Conversation of Hippocrates and Galen. Surgery in myths. The bas-relief that show us how Achilles retrieves the spear from the body of the Odyssey. This picture shows us Achilles provides surgical assistance to the wounded Talthyas. One typical theme of this period is almost all operations were carried out empirically, intuitively, without any legible scientific substantiation. There is a popular saying about surgeons. He is a God's doctor, and it is also supposed that this expression belonged to the Saint Cosma and Damian, who are considered to be the patrons of surgery. Cosma and Damian. Artist Fernanda del Rincon, Prada Museum, Madrid, Spain. On this picture you can see St. Cosmas and Damian transplant the patient's leg. Another picture that shows the same plot. These pictures illustrate the life and the work of those saint people. And of course, as you know, in that time it was rather dangerous to be a doctor and to practice surgery. The second period, the basic one, dated from the middle of the 19th century up to the 10th of the 20th of the 20th century. Once again, remember this period from the middle of the 19th century up to the 20th of the 20th century. At that time, The feudal system was replaced by the capitalism, and new industrial relations were developing. In the field of science, there was also made a rapid jump. Thanks to discoveries of chemists and biologists, narcosis, antisepsis and asepsis, on which the modern surgery is based on, were invented in that time. Exactly in this period the basis of topographical anatomy was laid. It was Nikolai Ivanovich Pirogov who firstly introduced this science for a substitution of surgical operations. He named it surgical anatomy, as the main aspiration of his researches was study the collocation of organs and tissues in a wound after performing various surgical operations. Nikolai Ivanovich Pirogov carried out into effect a unique in volume anatomical experiment for studying the topography of tissues and organs with the help of cutting frozen corpses, which received the name of ice anatomy. The third period, the physiological experimental one, dated from the 20s up to 50s of the past century. It was a short period but rather significant. It was greatly influenced by the works of the Nobel Prize winner Ivan Petrovich Pavlov. In this period, surgery got too closely bounded by its usual frameworks, and therefore all amassed knowledge was transformed into independent disciplines such as anesthesiology, reanimatology, urinology, neurosurgery, and others. During this period, our subject, alongside with the study of topographical anatomy, was enlarged in the field of experiments upon animals. The motto of the surgeons of the 1950s, a path to clinic lays through experiment, is quite actual even nowadays. In a number of sites of the Russian Federation and abroad, the departments of operative surgery and topographical anatomy bear the name of the Department of Experimental Surgery, since this is the place where all procedures and receptions of future operations are fulfilled. The fourth period, the modern one, or the period of restorative, organs saving and reconstructive surgery, characterized by the profound scientific search of new ideas and the development of the methods of diagnostic and treatment of the basic fundamental achievements of this science. In this new period that is being durating now, robotic surgery is developing, videoscopic surgery is developing, and now such methods as thoracoscopy, laparoscopy, and their variations are not rare in clinical practice. The second topic of our lecture, the history of the Faculty of Operative Surgery of Volgograd State Medical University. Let's discuss it. It was founded in the 1938, and its head was Professor Rodionov, who made a vital contribution to studying surgical aspects of the peripheral system. Being an outstanding surgeon who lived through the hospitals of the Second World War, he was one of the first people in the city who started operating patients with suppurative diseases of lungs. Since 1963, after Rodionov's death, the faculty was taken over and managed by the Professor Kanevsky up to the 1988. He was one of the first in the Soviet Union who was engaged in transplanting organs and tissues. His film, the main hero of which was Two-Headed Dog, became a great success and managed to go around the whole world. He should be also mentioned that owing to his invented method of seamless bond of vessels, the technique of transplanting kidneys and heart was considerably simplified. On the way of solving problem of transplantation, there was created the telemetric system CAVID for transferring the electrocardiogram to distance with subsequent qualified decoding it at the cardio center of Volgograd Regional Clinical Hospital. Since 1988 up to 1991, the faculty was managed by the Professor Bibolishvili, who, alongside with an excellent knowledge of camera art, made a great contribution to surgery of liver and was the first performed a laparoscopic surgery in our city. Since 1992, the faculty has been managed by Professor Vorobyov, who nowadays can already be called the founder of a brand new fundamental approach in the field of experimental medicine. He is considered to be the author of numerous original operations upon animals. It be also added that at this time the scientific development of our faculty lies in studying surgical anatomy of operated abdomen and in improving methods of the operations under conditions of jointing process. The third topic, the concept surgical operation and the classification of operations and their basic stages. Apart from everything mentioned, our discipline also studies surgical operation. But what is it? Operation is a mechanical influence on tissues of a patient with either medical or diagnostic purpose. Also the definition that you should write down. A mechanical influence on tissues of a patient with either medical and diagnostic purpose. And let's remember that operative surgery, the doctrine of surgical operations, the rulers and methods of their implementation. The doctrine of surgical operations, the rulers and methods of their implementation. Now let's relax a little bit and let's look through the illustrations. As you can see, 1514 in this year it was offered a manual for surgery. the technique of hernia repair in the 13th century. The classification of operations. It is rather large. Let's see the first aspect. By the relation to integuments. All the operations can be divided into bloody and bloodless. As an example for bloody operations, we can take any traditional operation when a surgeon should cut and should make a wound, an operative wound. For example, appendectomy. We cut the skin and some amount of blood will flow. Bloodless. Some types of endoscopic interventions are the example of this point. Also, the dislocation reduction we can use as an example, because during this procedure the surgeon uses his hands to improve the pathological position of the bones, and these movements also follow the definition of surgery. The second aspect, by stage or by the period of time. There may be one-stage operations, two-stage operations, and multi-stage operations. The term stage may be changed on the term momentary. You can meet different terms in different manuals. As about one-stage operation, it's rather simple to understand and to realize. We can do everything we want during one period of time. But sometimes, when the condition of the patient doesn't allow us to do it, or if the technique of this operation requires the period of time, for example, for patient's tissues to repair, we will divide this operation into two or more stages. And the key moment that in all such cases we plan those stages. The third aspect, operations may be primary and may be repeated. During the repeated operation, we should improve the same pathological condition as at the primary during the primary operation. But if we compare primary and repeated operations with one momentary or two momentary operations, we will find that in case of repeated operations, the surgeon expected to do everything he wants during the first period of time. But the clinical situation didn't allow him to do it. For example, the abdominal hernia. When a patient doesn't follow the surgeon's recommendations after operation, I mean excessive activity, I mean excessive tensions. Sometimes hernia, abdominal hernia, may appear again in the same place. And in this case, a surgeon will have to repeat the herniatomy and hernioplasty using the same method or using the another method. But this kind of operation may be called repeated, because neither surgeon nor a patient expected to get in this situation. I suppose you understand it. The fourth aspect, the classification of the operations based on timing. There may be emergency operations, urgent operations, and scheduled operations. Emergency operations are the operations that cannot be postponed for any period without endangering the patient's life or health. The situation when waiting is nothing more than just killing. Usually, those operations are related with bleeding. For example, the lesion of the main vessel, or the rupture of the internal organ, especially parenchymatous organs such as kidney, such as liver, or such as spleen. Urgent operations are the operations that can be postponed for a short time to clarify the diagnosis or prepare the patient. Pay attention to the words to clarify the diagnosis and to prepare the patient. It means that we should delay this operation, this type of operations, only for those purposes, not for any others. As an example, we can take acute appendicitis and appendectomy. We have several hours, not more than 6 hours, to confirm the diagnosis, to perform clinical examination, to perform ultrasound diagnostic, to take blood analysis, maybe in dynamic, to be sure in the diagnosis. And of course, if our patient is an older man or woman, we should call and we should organize the consultation of the therapist. We should perform electrocardiogram and so on. And all these things have the only one aim to decrease the operative and anesthesiological risk of the operation. And the third group, scheduled operation, that can be postponed indefinitely without endangering the patient's life and health for any time. Why we should delay those operations, those type of operations? To wait for better conditions. For example, we may ask the patient to come in winter when the weather is cold. As you know, summer and severe heat is not a good moment for scheduled operations, because this is not a good situation for the patients, and so on. As an example, we can take also the abdominal hernia without complications. If the patient follows all the recommendations of the doctor, of the surgeon, he will probably avoid severe complications. And in this case, we can use and we should use any time, I mean the better period for a patient first of all to perform this operation. So, the fifth moment of the classification for the purpose of the operation. There may be medical operations, diagnostic operations, medical and diagnostic operations, anesthetic operations. Medical. As an example, cholecystectomy. When we remove the gallbladder with gallstones and with inflammation, we treat the patient. Diagnostic. Here we can use any type of biopsy as an example. For example, laparoscopy and the biopsy of the liver in patients with cirrhosis allows us to make the differentiation between the cirrhosis and the hepatic cancer. Medical and diagnostic mix those two aspects. For example, when we remove the tumor of the skin, we will probably perform the biopsy, and the following stages of the treatment will depend on the result of this examination. If it's a benignant process, the treatment will stop soon after the wound will disappear. And if this is the cancer, we have to use additional methods of the treatment and of the prophylaxis. And we should send, first of all, we should send such kind of patients to oncologists. Aesthetic operations. For example, if a woman wants to increase the size of her breast, and she supposes that she will look better after the operation. In this case, she doesn't have any pathological process in her mammarial glands, and she doesn't need any diagnostic procedures, but she supposes that after this operation her quality of life will be much better. This is her right, and she goes to the cosmetic surgeon. Sixth point, by the finite result. First one, radical operations. The definition is the complete removal of the pathological focus or tumor in oncology. Palliative operations mean maximum removal of the pathological focus or tumor. And symptomatic operations aimed at eliminating complications of the disease, the purpose of which is to reduce the risk to life and to improve the quality of life of the patient. The difference between first two points will be, for example, let's take the stomach cancer. We, as a surgeons, perform an operation. Imagine that this is the resection of the stomach, and we remove all the tumor, and we hope we treated this patient completely. But sometimes, in any time after the operation, metastasis may grow and may appear, and in this case we cannot tell that we performed the radical operation. It was not a complete removal of the tumor, just maximum removal. As about symptomatic operations, as an example we can take the drainage of Hallederhas in case of the pancreatic head cancer. In this situation, we are not able to remove the tumor because of any reasons. Maybe the tumor is rather big, maybe it involves the neighbor anatomical structure, maybe the age and the condition of our patient doesn't allow us to do it. But we should and we have to reduce the jaundice that usually is the main and the most dangerous symptom in this case. And this patient may even die because of the jaundice and its complications. And we have to save his life. We have to improve his quality of life, because jaundice is usually related with the intoxication. In this case, In this situation, we will probably use some kind of symptomatic operations. I've told you before, as an example, we can take the drainage of Haledachas, internal or external. We will reduce the jaundice, but we didn't remove the tumor, the primary tumor and its metastasis. We will improve the quality of life of our patient. We will prolong his life, but we won't treat the disease completely. Then, seventh point, the operations may be combined and may be simultaneous. Combined operations in different areas of the body in the same time, and simultaneous on one area of the body or on one cavity in the same time. As an example, combined operations, trauma, car accident, trauma, and thoracic surgery is performed, for example, when surgeons sew the wounds of the lung, and abdominal surgery when the surgeons remove the ruptured spleen. They should do it in the same time, synchrone, to stop bleeding immediately, and simultaneous operation. For example, when we perform cholecystectomy, and in the same time we can perform hernioplasty to remove the abdominal hernia. If the situation allows us to do it, we can. The eighth point, by body area. Operations may be cardiovascular, may be abdominal, may be orthopedic, and so on. The ninth point, by type. Amputation. What is this? The removal of a part of the body, usually a limb or finger, with a bone cut. Pay attention, with a bone cut. Exarticulation. The removal of a part of the body, a limb, by separating the joint. And the difference between amputation and exarticulation will be at first example with a bone cut, at the second one by separating the joint. Resection, the removal of the entire internal organ or its key part, I mean lobe and segment. For example, lobe and segment of the lung, of such part that has its own name. Then replantation, reconstruction, excision, transplantation. These terms you can often meet in medical literature and in the different surgical descriptions. So it was the classification, short classification of the operations. Ivan Petrovich Pavlov used to say that doctor is originally a mechanic of human body, and his initial mission is to learn how to repair these mechanisms. And while speaking of such mechanics of human body, we should first of all refer to surgeons. But it is also necessary to mention that the hands of a surgeon can affect only the life, can affect not only the life, but the death of a patient as well. That is why in the history of surgery we have several cases when surgeons committed suicides after having made unsuccessful operations. Because of this, in order to avoid such situations, the well-known surgeon Burdenko recommended, while performing an operation, to be guided by the triad determining the actions of the surgeon, namely, triad, 3 points. First one, anatomical ability. Second one, technical opportunity. And third one, physiological permission. Physiological permission. Each operation has 3 stages. First stage, here is written A, operative access. A part of the operation that provides the surgeon with an organ exposure. A part of the operation that provides the surgeon with an organ exposure. Second one, or here B, operative reception or operative method. The main part of the operation on the affected organ. The main part of the operation on the affected organ. And the third one, C, completion or exiting the operation. When speaking about operative access, we mean a place on the skin where a cut is made. The operative access should be of small traumatism and must provide some open space for a lumen of a wound. At making a choice on the operative access, an operative access needed, a surgeon must define the shortest possible path to internal organs. But, however, the shortest path is not always the best one, since a scalpel of surgeon may face vitally important organs standing on its way. Thus, the operative access is worked out judging by the topographical and anatomical peculiarities of the given region. Once again, all these questions are for you to be seriously learned during this year. It's important, my dear friends. As for the dimensions of the operative access, it is in each case up to a surgeon to decide how to make it. In fact, it all depends on the qualification of a surgeon. An experienced one will never operate within a small cut, since the last reduces availability. And there is even a saying, the bigger a surgeon, the bigger a cut. Moreover, at purulent operations, small cuts are even harmful, because they do not provide any sufficient drainage of a wound. But at the same time, those ones which are too big can cause an additional trauma, deteriorate the cosmetic effect, and frequently become the reason of hernia. That is why, when deciding which cut to make, one should always refer to the ruler of the golden mean. At planning a cut, it is also essential to take into consideration the thickness of a hypodermic fatty cellular tissue, the depth of location of an operated object, and also the amount of manipulations needed. It is also important to mention that when choosing the operative access, it will be more desirable to avoid any intersections with vessels and nerves. At last, we come over the third stage of an operation, completion. The third stage, as we know. But at first, we will touch upon several things which are necessary for you to understand, such as all the tissues should be sutured layer for layer, skin with skin, muscle with muscle, fascia with fascia. For each tissue, there are special suture materials. For skin, for example, is silk, for subskin loose connective tissue, capron and catgut. For muscle, we also use catgut. For aponeurosis, silk and lavsan are used. For intestines, capron and semi-synthetic materials such as polyester, perlon, supramid, and so on. For vessels, of course, supramid. In surgery, there is a rule. Everyone should know in order to make an operational wound beautiful: symmetry, parallelism, and perpendicularity. Once again, symmetry, parallelism, perpendicularity. I think we will discuss the peculiarities of these rulers, and maybe we'll remember some manual skills on our practical classes. Now I offer you to enjoy some masterpieces, and you can see that surgery in art is very spread all over the world, and in different famous museums you can see, you can meet, and you can enjoy the masterpieces created in different centuries. My dear friends, our lecture has finished. I wish you good luck, good health, and I hope to see you on our practical classes. Thank you very much. Goodbye.